Okay, welcome everybody to the afternoon session of the Canadian Global Oncology Workshop. It's my absolute pleasure to be here. We've now been holding these workshops this is our third workshop, and it is so nice to be here, seeing our colleagues who we've been on Zoom calls for the last 3 years, almost monthly, and seeing them in person and catching up. I'd like to thank our colleagues at McGill University for welcoming us so well, and thank you to them. So we're going to kick off this afternoon's session with a session on global oncology in the context of war. Our first speaker is Dr. Richard Sullivan, and Dr. Richard Sullivan is a professor of cancer and global health at King's College London and Guy's Comprehensive Cancer Centre. He's director of the Institute of Cancer Policy and director of the Centre for Conflict and Health Research at King's. He is an NCD advisor to the World Health Organization and World Bank. Richard was formerly clinical director of the Cancer Research UK for almost 10 years. His global cancer research programs cover quite a broad array of topics, including cancer system strengthening, financing, political economy, global cancer surgery, particularly virtual reality enhanced surgical simulation training, as well as studies into social welfare and cancer care and conflict. He also directs a number of major research programs in conflict and health with a special focus on the Middle East, including health security, intelligence, global health security, and health systems strengthening in conflict. And topically, as he puts it, he's actually in the Ukraine right now, where he'll be presenting. The title of his talk is Cancer in the Time of Conflict, From Ukraine to the Narcowars. So welcome, Professor Sullivan, and really looking forward to your talk.
Scott, thank you very much indeed for that lovely introduction, and I'm sorry I can't be with you all. It's a great pleasure really to kick off what you're going to hear from much more deep expertise from Omar, Shamieh and Tezer Kutluk in a moment about cancer care within conflict zones. But I'm going to really maybe spend the next 20 minutes giving you a sort of stage setting discussion around the work we've been doing in conflict areas. And just to say, this is just one of a number of different themes we have within King's College London. It's slightly unusual as a university because we not only have the sort of Faculty of Life Science and Medicine, we also have a very big faculty in security studies. And I guess the cancer and palliative care interfaces with that aspect of security studies. So let's start with a little bit about conflict settings. The first thing is, and this is maybe going to seem a little bit self-evident to you, although, but it's important to make the point that the nature of conflict and insecurity is what really defines the health issues that we have to deal with. And a lot of these, of course, are not just conflicts in and of themselves. There are also natural disasters ongoing in these countries. There are major public health issues outside cancer that have to be dealt with in a humanitarian setting. And of course, the nature of the conflict and insecurity really frames the experience of those populations and also frames what can be done. Now, if I go back 25, 30 years ago to when I first started in this area, we really weren't talking about cancer as being a major issue for humanitarian issues within conflict settings. Why? Because nearly all the populations we were dealing with had not been demographically transitioned. In other words, they were mainly young populations. They were really infectious diseases, child and maternal mortality. This has changed dramatically. So what we've seen over the last 20 years is contemporary conflicts occurring around the world in demographically transitioned countries, for example, Syria, which already had a very high cancer burden before it entered into a civil war in 2011. But also more importantly, even in sub-Saharan Africa now, what we're seeing is a much quicker aging population in refugee settings. So those, of course, have knock-on effects to the impact in terms of cancer. So although we still have huge issues in terms of infectious diseases, child and maternal mortality, cancer and palliative care now generally is becoming a significant health burden in nearly all conflict settings. But as I said right at the beginning, context is everything. And one of the things I think we struggle with when we're thinking about this is, what do we mean by cancer and palliative care? It is very different if you're a refugee in a sort of demilitarized zone on the Turkish border compared to a refugee moving across borders in the Sahel region, or, for example, you're just a member of the public caught up in one of the narco war boundaries in Mexico. And our colleagues out in Mexico, for example, describe huge impact of these narco wars in terms of movement of patients and also the security of the healthcare professionals. So the context defines really what we can and cannot do within cancer and palliative care. And more broadly as well, one of the other things that war creates is other major challenges. We've known now for many years that conflict ecosystems, toxification of the environment is leading to increased antimicrobial resistance. Of course, that has a knock-on effect. We take for granted the ability to treat sepsis and cancer. In many parts of the world in conflict settings, the levels of AMR are incredibly high, and that adds on a layer of complexity to cancer care and control that we don't see in other places. And also this problem of the ecology of war. A lot of war is essentially protracted conflicts, and they maintain themselves well beyond the end of when the active conflict is. And of course, this creates a completely different environment where people really struggle with their physical, psychological, and social health. So these ecologies of war create some very different environments. And the other thing is to make the point here is that the way we think about the systems, it's very different in Western terms. So a lot of work has been done, particularly in the Middle East, asking the question about how we reframe the whole sense of trauma in the Western sense and how that frames our treatment of cancer patients. And in many countries, of course, we're dealing with conflict populations that are in low income, they're very fragile, they've got chronic ethnic unrest, poor governance, repressive governments. And this creates a very different environment for creating strong and stable cancer care. Moving on, I guess, is what do we know now about cancer and conflict? I think the first thing is today that reliable data and intelligence has been hard to come by. You're going to hear from Tezer Kutluk in a minute about some amazing data they collected in Turkey. But generally speaking, if you look backwards over the last 20 years, the data on cancer burden and also on cancer outcomes has been really poor. We did a piece of work a couple of years ago looking at the impact of armed conflict on cancer among civilian populations, and we found very little decent data. One excellent study that Paul Spiegel, former director of the UNHCR, did, published in the Lancet Oncology, looking at cancer in refugees in Jordan and Syria, found, I think it was one, two, three, four, 6 studies that were worthy of a systematic review. But even then, when you look at those particular studies of cancer burden in refugees, there are huge issues, particularly in terms of case finding. So a lot of the case finding within these studies simply does not match up with what we know was in those environments. So reliable data intelligence is hard to come by. The other thing we know, of course, is that we're dealing with some very different ecosystems here. We're dealing with pathways for healthcare professionals and patients which are multidirectional, they're multinodal, they tend to cross national borders. And of course, you have to take into account both patients and healthcare professionals move around. And this is what we mean by the changing therapeutic geographies. And again, wonderful book by an old friend and colleague of mine, Omar, about exactly this sort of subject, but in the context of Iraq. Asim Yosef, a good colleague and friend from Pakistan, has done some absolutely remarkable studies looking at the pathways that Afghan refugees take to actually access cancer care in Pakistan. And that map on the left there, the darker the color, the more patients are moving from those particular regions into Pakistan to his center to access care. And what you can see there is very large numbers coming from places like Herat, Ghazni, even down in the Pashto heartlands in Kandahar and Helmand. Now, these are pathways which take weeks, and they are enormous distances, and they're all entirely due to the security situation, and how patients move is entirely predicated on the security situation at a given time. And of course, those delays in diagnosis and eventually delays in treatment have significant consequences for downstream outcomes. The other thing we know as well is that conflict also has a significant distorting effect on cancer services and systems. It's very well acknowledged that in conflict situations, we tend to get black market economies arising. That's well known. The corruption elements are also well known. Perhaps what's less well known is the way that humanitarian organizations engage in conflicts. And this is a nice piece of work from Shamieh, who was a PhD student with us, looking at breast cancer in Gaza, in the occupied Palestinian territories, and showing that well-meaning humanitarian efforts to try and engage in the breast cancer problem within Gaza, very high levels of breast cancer there, demographically transitioned women's population, they'd approached it in entirely the wrong way. And instead of taking this as an end-to-end systems problem, instead they had literally just bought um, huge numbers of mammographic screening equipment in the mistaken belief this would improve outcomes for Gazan women, which of course it didn't. And what it simply did was add simply to the cost, more out-of-pocket expenditure, but no improvement in outcomes. So the delivery mechanisms as well can become seriously distorted in conflict settings, particularly when you have actors working in it who really don't understand the cancer ecosystem. So what about finding solutions then? Well, the first thing is to say is cancer contemporary conflicts, I guess, it's had a relatively new outing. The research from the Research for Health in Conflict program, from people like Tezer and Omar, it's really the first time we're getting decent data to make decisions. When you look at Libya and Syria, what you do see, though, is social capital conflict has really long-lasting impacts. What do we mean by that? We mean loss of healthcare professionals abroad. In Libya, many of the trained cancer care professionals have left. They've gone to Tunisia, Morocco, to Italy. Very unsafe for many of them to go back. Syria, our estimates are something like 80% of the cancer workforce has also left. The other question then comes in, what about adapting cancer care during conflict? Who does what and how? And part of the problem here, of course, is that cancer and palliative care is not a substantive element with many national non-governmental organizations. So there are significant challenges to go along with finding solutions. Ukraine, well, Ukraine's really been a really interesting case point here. First of all, there's an entirely new cancer care ecosystem. This is a country that essentially had gone through the demographic transition, that had a proper national cancer control program before the 24th of February, that had a number of cancer centers across all the different oblasts. And what we've seen there is some really radical changes. We've seen two things mainly. One is the impact, of course, on the wider attacks against healthcare infrastructure. So particularly recently, power outages. And cancer care, for example, is one of the most power hungry clinical disciplines in terms of the need for power to run CT, PET scanners, radiotherapy, OR. So the power outages, because of the indirect attacks against the critical infrastructure, have had dramatic effects. What's also interesting is the fact that some of the old school treatments, for instance, the Cobalt 60 machines they have there, have actually are much more resilient in conflict settings than the modern Linacs. They can handle power outages and spikes far better than modern Linacs. The other learnings we've had from Ukraine is adaptive networks. By far, the fastest numbers of the fastest adaptation to the cancer problem has been the patient organizations who've been able to work with individual groups and units within Ukraine to move patients around to different centers in what is essentially a very kinetic, very difficult setting. And I thoroughly recommend, if you want to go and listen to more about this, going on to eCancer and listening to the special network on cancer conflict in Ukraine. There are some amazing testimonials from patient organizations about how they've been working and how they've adapted. But Ukraine is teaching us a whole new level of solutions, really, for contemporary conflicts and cancer. And really, finally, to end up with this, which is a lot of the issues right now, but of course, are based not just on practice, but also on understanding, on research. The research ecosystem within conflict and cancer is relatively new, but a part of this is about developing a new political economy of cancer and conflict. This is understanding not just the burden and also treatment pathways, but also how to embed affordable and equitable approaches to treatment within individual settings, whether it's host nations like Jordan and Turkey, or in IGN, NGOs, non-governmental organizations working in refugee camps. And that requires a very different multi and transdisciplinary approach. And again, it's well worth going and looking on the Research for Health in Conflict, MENA.org website. There's a whole load of these reports that have now been put out on Lebanon, Jordan, Turkey as well. Tezer may talk about a little bit more about that in a moment. But these are really important because it pulls together a lot of the extant knowledge about how to drive cancer and palliative care as both a research area and also a community of practice within conflict settings. And with that, I think that's my 20 minutes up. I'm delighted to hand back to the chair. Thank you very much indeed for listening today.
Thank you very much, Richard. And we're going to hold questions until all three speakers have had a chance to present, and then we'll have a question session at the end. Our next speaker is Professor Tezer Kutluk. Dr. Kutluk graduated from Hacettepe University Medical School in Ankara, Turkey, and he did his postdoctoral fellowship and Fulbright scholarship at MD Anderson Cancer Center in the United States. He has served as a leading healthcare executive at Hacettepe University, including, long list here, Vice Director of Children's Hospital, Director of the Oncology Hospital, Director of the Children's Hospital, President of the Institute of Child Health, President of the Institute of Oncology, Board Member of the Institute of Health Sciences, a member of the Senate, and most recently, CEO of Hacettepe University Hospitals. He has numerous publications in peer-reviewed and international scientific journals and citations in international medical journals. He has long-term experience on NGO management. He is a board member of the UICC. He is the president of the Turkish Association for Cancer Research and Control, president of the European Cancer Leagues, president of the Turkish National Pediatric Society, president of the Turkish Pediatric Oncology Group, and chair of the Turkish UNICEF National Committee. He was named an honorary fellow of the American Academy of Pediatrics in May of 2014 and was the president of UICC from 2014 to 2016. He was the NCD Alliance board member at UICC from 2017 to 19, and he is currently the chair of the Department of Pediatric Oncology at Hacettepe University. So, Dr. Kutluk, welcome, and very looking forward to your talk.
Well, hello, everybody. Thanks, Dr. Berry, for kind introduction. During the next 15-20 minutes, I will try to reflect our Turkish experience for cancer care for the refugee population living in Turkey. So, according to the United Nations High Commission on Refugees data, Turkey is hosting the largest number of refugees with 3.8 million people in Turkey. The Syrian refugees were under the temporary protection and persons under international protection from other countries, mostly from Afghanistan and Iraq and Iran. As of 15th of September 2022, number of Syrians under temporary protection is about 3.6 million. And as of the end of the 2021, there are 30,000 international protection holders. So if we look at the global facts and figures, I will not read all, but there are 89 million forcibly displaced people worldwide, and 69 of originated from just from 5 countries. 6.8 million are from Syria, 4.6 million Venezuela, 2.7 from Afghanistan, 2.4 million from South Sudan, 1.2 million from Myanmar, and 83% were hosted in the low and middle income countries. If you look at the income level and the dissemination of the refugee population around the world, the high-income countries, which account for nearly 2/3 of the global wealth, hosted only 17% of people displaced across the borders at the end of the 2021. Low-income countries share only 0.5% of the global gross domestic product, yet host 22% of the people displaced across the borders. How is the legal situation of the refugees in Turkey? Turkey is a party to the 1951 Refugee Convention and its related 1967 protocol. However, Turkey put a geographic reservation to implementation of the Geneva Convention, which means that Turkey entitled refugee status only to the people from the European countries. So refugees are from the European countries. The international protection holders are from outside the European countries, and we named the Syrian refugees as temporary protection holders. These are the different status for refugee population or for forcibly displaced people living in Turkey. Almost 95% of refugees in Turkey are Syrians, as I said earlier, 3.6 million. After the Syrian, largest group is the Afghan under international protection holders, and the almost 20,000 people Afghani, and followed by Iraqis with around 5 million people. Also, according to the statement made by the Ministry of Interior in March, the number of the Ukrainian refugees arriving in Turkey exceeded 20,000. How are the health rights of the refugees in Turkey? I will not read all, but the rights are different for the people who are under the temporary protection status and the international protection status. In any way, Turkey is providing a lot of things offering a lot of health access to refugee population in Turkey. All persons registered under temporary protection have right to access free healthcare services provided by public institution. As a rule, temporary protection beneficiaries can access free healthcare services in the province where they are registered. They can visit primary and secondary healthcare institutions and the migrant health centers also. They can also directly approach secondary and or tertiary health institutes. However, it is not possible to access free service in the university hospitals or Ministry of Health, Training and Research hospitals without a prior referral. If they have a prior referral, they have right to access this high-level care also in Turkey. So the palliative care in Turkey, after the year of 2000, we have made some progress. Still, we have some ways to go, but Turkey was based on the Global Atlas Care. Turkey was in Group B in 2011, but went down to Category 3A in 2020 under the title of the Isolated Palliative Care. So we recently published a comprehensive literature review of the situation of the palliative care in Turkey in eCancer. You can find the article in the eCancer. So these slides shows the increased bed capacity of the palliative care in Turkey, but still not completely integrated with the oncology services. We still some ways to go, although there are some progress. Recently, I also sent a quick survey to my colleagues from the southern universities, which are having a lot of refugee population. The survey was sent to 21 southern universities in Turkey. The refugee access to palliative care was available only 12 of those 21 university centers. When the focus was in Turkey, the population is aging in Turkey. Cancer is listed as the second most common cause of mortality, which accounts almost 20% of all deaths in Turkey. In addition to all these, Turkey is the country hosting the highest number of the refugees in the world. So, considering the importance of the communication with patients and their relatives and cultural challenges in palliative care service provision, refugees have many disadvantages due to language barrier and different cultural beliefs. Also, 83% of the refugees live in low-income countries where palliative care services are not developed, which means that refugees living in these countries are even more disadvantaged in terms of accessing to palliative care services. It is hard to read, but I will give a quick summary. We published the cancer among the Syrian refugees living in the city of Konya in the Journal of the Conflict and Health. We published the data of the 268 Syrian refugees with cancer diagnosis. 230 was adult patients, and then 38 children with cancer. This is a small sample, but we just wondered what type of cancer, what is the treatment abandonment rate, how successful the access to cancer care, and what was the outcome of the care, the mainly survival rate. So basically, treatment abandonment was around 10%, both in adult and children's population. The advanced disease, metastatic disease, was seen in 40% of the adults and 43% of the children with cancer, and the survival rate was 37% in adult population and 70% for children with cancer. So 70% survival rate for children with cancer, which is quite acceptable, because our national estimates of the overall childhood cancer survival in Turkish children is around 70%. But the survival rate in the adult population is less than the Turkish population, which is around 50-55% in Turkey at the moment. This gives us an idea to do more research in the southern Turkey, because we were very much aware that although the Turkish government were spending a lot of money from its own sources and also from the international sources, the care is not only dependent how much money you spend. There are some factors started already in the pre-migration period, disrupted healthcare, lack of reports, lack of security, and it continues during the migration. So the outcome is affected from all of these, not only the care you provided when they reach their final destination after the migration. So the problems continues during the migration: physical, mental stress, violence, dangerous travel, loss of network, lack of medical care, etc. And when they reach to host country, more problems are occurring from the migrant perspective and the host country perspective. I will not read all, but this is really a very complex situation to manage the care in the refugee population. So we, based on our experience from the city of Konya, it was a small study, then we designed a major study in southern Turkey in collaboration with Richard Sullivan and his team, and my team in Ankara, Hacettepe, and the colleagues from the southern Turkey. So we went to the major university hospitals located in southern Turkey, get the ethic approval from the university. We were able to access to data of the 1,500 cancer cases. As Richard said, it is very difficult to quality data for the refugee population anywhere in the world. But this was good for us to access to good quality data in the southern Turkey. So I will not, this is not published yet. We are in a process of submitting this data, but I would say that the major outcome of this work was what we found as the survival rate is 17% in adult population and 37% long-term survival in childhood cancer Syrian refugees. This is unacceptable, which is quite low comparing not only with the Western country, but also comparing with many middle-income countries. So this was the major findings from our work. So we are still continuing to work on the refugee population, but we are going to share how can we make changes happen for the sake of the refugee population living in Turkey. So I would like to thank the team, my colleagues, my team at Hacettepe, and my collaborators, which is Sullivan, King's College people, colleagues from Jordan, Lebanon, Birzeit University, and the colleagues from the city of Konya and from the southern universities. This work is funded by the United Kingdom Research and Innovation, GCRF, Research for Health in Conflict. Thank you for the attention.
Thanks very much, Dr. Kutluk. And it's notable and remarkable and inspiring that you're doing research in these areas. Both you and Dr. Sullivan have talked about the research that you're doing in these conflict zones and how that can inform improving care for these patients. So thank you for that. Our last speaker in this session is Dr. Omar Shamieh. He holds the Palliative Care, Pain Management, and Psychosocial Oncology Chair at King Hussein Cancer Center in Jordan. He also serves as the chairman of the Jordanian National Palliative Care Committee and leads the Jordanian National Home Care Initiative to improve community and home care in Jordan. Dr. Shamieh is the founder and leader of the Center for Palliative Care and Conflict. Since 2018, Dr. Shamieh is active in research on cancer, palliative care, pain and symptom management.
My pleasure.
Siri's checking in here. Dr. Shamieh is active in research on cancer, palliative care, pain and symptom management, clinical reported outcomes, supportive care, quality of life, and psychosocial oncology. He has a regional and international reputation for palliative clinical care, education, training, and advocacy research. He led the 2018 first National Palliative Care Strategy in Jordan and the first study on palliative care and home care economic evaluation in Jordan. Dr. Shamieh served as Jordan government scientific advisor and WHO advisor on palliative care from 2016 until the present, and he currently chairs or is a member of a range of research funding or policy committees for R4HC MENA, USAID, and EORTC, as well as the Ministry of Health and Jordan Medical Council. So again, another esteemed colleague, and I'll hand it over to you.
Thank you very much, Barry, and everybody for the introduction, and I'm glad that I was able to join today. Thanks, Richard and Tezer, for your wonderful talk. I don't want to repeat what my colleagues mentioned about the really global increase in the number of refugees and displaced people, and it seems that this problem is not ending and it's taking longer than expected. The Middle East, as my colleague Tezer mentioned, that the number of refugees increasing, and the problem is the response for the United Nations and humanitarian emergencies, protection agencies, that the focus is only for protection and lots of disadvantage for the NCDs and care of cancer.
Dr. Shamieh, just quickly, I think maybe your microphone might be in the back. We can't hear you very well. Our colleagues who are in multimedia said your microphone might be facing backwards. If it's coming through your headphones. Yeah, perfect.
Apologies for that.
Yeah, then much better. Thank you.
It's better now. Okay. Sadly saying that the countries and the nations providing support for the refugees probably also maybe fueling the conflict around the area here in the Middle East. And in Jordan, there are major hits happening in the past few decades, whether initially from the Palestinian refugees, Palestinian conflict, and also the Iraqi, and then the Syrians, and now we face also many members coming even from Yemen. Our colleagues from KHCC and AUB has done many research regarding the cancer care and humanitarian crisis, and as probably basic information that the really the country of conflict like Syria, there is a huge destruction of the healthcare infrastructure. There are lack of all spectrum of cancer control, from promotion, screening, early detections, also diagnosis and treatment, and also there is no palliative care. And there is no room for either, there is no room for either curative care or palliative care. And there is no such really data, and the risk for healthcare workers is tremendous, either through because they either died or even left from the country. Now, the neighboring countries, like hosting countries like Jordan and Turkey, there is a really diverse country situation depending on the economic status of these countries. As we speak, there is existing problem in the even the healthcare system in a country like low middle income country like Jordan, and the response to crisis usually is limited to basic needs and some communicable diseases. No focus on non-communicable diseases, and there are many Syrians, for example, they cross borders to Jordan to continue treatment with loss of data or even loss of records of what previous treatment was received. And unfortunately, there is in Jordan, the UNHCR has zero budget for cancer care or even palliative care. And that's even the same for UNRWA, which is caring for Palestinian refugees. There is the status of palliative care development in the MENA region is also variable, with the low provision is probably the most current situation in many countries. Although Jordan, there is, as mentioned by Tezer, there is a local provision, the King Hussein Cancer Center, where we practice probably the most comprehensive palliative care center in the region, although there is still a lot to be done in the national level. The Jordan, just very quickly, the population is about 11 million. It's low middle income country, low GDP, high unemployment rate, and it's poorly resourced. And as I mentioned, we faced many refugees hits. The cancer incidence now in 2022, probably around 11 million, with about 4 million of non-refugees or non-Jordanians. Cancer death about 3,500 cancer deaths per year. And as we mentioned, the refugees and immigrants have poor access to cancer care in Jordan and even in the Middle East in general. There is a high burden of physical, psychological, and socioeconomic challenges for them. And as we mentioned, until recently, palliative care was absent from any humanitarian emergency response. And also, again, the data problem exists, whether in Jordan or neighboring countries. And in a last survey we have done about the palliative care development, there was still a lot to be done in the development of palliative care. Along with colleagues from King's College London and the support from R4HC, we have done a qualitative study to look into what are the needs of refugees in Jordan, and especially with advanced cancer. And we have done probably around 29 refugees, 22 some of them patients, some of them caregivers, and really the major themes was great burden in psychological distress and sustaining social support. And this is because either because of the lack of support or difficulty to access support for them. The second problem is the knowledge and uncertainty. There was poor communication between the healthcare providers and the patients with cancer. And the other issue is the family anxiety and support roles, because of the disconnection between the social network of those refugees. There was a problem in really maintaining social support. And this compounded trauma of the war and poverty, on top of that is cancer that faces also another layer of the financial burden and getting really treatment. This is fractured families and network was a major issue for refugees, and this data revealed challenges obtaining also social support in the community, and there was some ineffective communication, and we really need to work on more effective communication between healthcare providers as well as the patients. Now, there is another study that was done to providing person-centered advanced cancer care within host population affected by conflict in the Middle East and what matters to the patients and families. And this was really to find specific concerns of patients with advanced cancer and their caregivers to inform appropriate person-centered assessment and care. And again, the same problems with the information and communication decision-making role. And there was also the priorities and concerns for care and support, and the role of spirituality and Islam was a major finding among those patients, most of them actually also Muslims. Just to mention that spirituality care probably is, in a professional level, probably is lacking in the healthcare system in Jordan and even in the neighboring countries. There was also unmet support needs and families are caregivers of cancer patients. Another study which we have conducted also with colleagues from King's and also that partnership with Hacettepe University about what matters to children and young people, advanced cancer and conflict, since there is really scarce data about the needs and the concerns of pediatric oncology patients. And again, the priorities was physical pain and symptoms was a major problem, psychosocial concern and needs. And there is the faith and reliance on God. Spirituality and uncertainty over future was also a major importance for them. The social dimension and burden of caregivers again is existing. The other themes also was communication and information sharing and quality of care. That's also coming another study which we are planning to publish soon. Now the prevalence of chronic diseases for Syrian refugees also in Jordan is another layer, not only cancer. So there is a problem with NCDs and having access to them. As I just to highlight that Jordan hosts more than 670,000 Syrian refugees. These are registered under UNHCR, and around more than 3 million Palestinians, mostly either registered or not registered in the UNRWA. Most of those people are actually living in the community, and unfortunately, again, that those people have no access to cancer care or palliative oncology. Implication, patients, particularly refugees in Jordan, often experience unmet multidimensional needs, symptoms, and concerns. And the really high quality healthcare is needed for them. And the further investigation is needed to understand some of the cultural and spiritual assumptions that population underpinning evidence generated and should be scrutinized. Adequate training is important, paramount for people who are caring for those refugees, whether in urban or even in the camps. Families should be trained to really give support to patients, and more support also to reduce the burnout and throughout the disease trajectory, even after death. Now, really to end this, that although palliative care is an essential component of any humanitarian crisis, however, we really need to make efforts to find a way how to support those refugees who are living in those communities, how to really tackle their NCDs, how to find way to support their cancer cares, because this is really something which is the international community is shying from. There are really something unbelievable to have around 600,000, around million or 2 million people who have no access to cancer care except for some donations and some funds which is not really reliable or we cannot rely on, because most of those people will present late, as mentioned also by my colleague Tezer, similarly in Jordan. And even when they present late, the existence of palliative care outside tertiary hospitals probably need to be accounted for and need to be developed. I think this is my last slide. I would like to thank really the organizers. I'd like to thank Prof. Richard Sullivan, Richard Harding from King's, Tezer, and also the KSCC teams and King's team and Hacettepe teams. Thank you very much for listening, and I'll give the mic to you back. Thank you.
Thanks very much to all three speakers for very powerful talks. Thank you very much. And we've been talking a lot at this meeting about the power of collaborations. And it's clear that you and your three teams are exemplars of that and doing really meaningful research. And we have time for some questions now. Maybe I will lead with the first question, which is the need is great. You have done excellent work describing the need in various settings, including some very excellent qualitative patient-centered research. And yet, UNHCR does not have a budget for palliative care or cancer care. So who's the audience for this research who is going to help address this? Who is the organization that's best placed either nationally or internationally to help address these issues that you've identified in your research?
Do you want to get that, or?
Yeah, why don't you start?
Well, yeah. Well, we have many layers of audience. First of all, there is a lot to be done in the development of palliative care for even Jordanians, whether it's from our local community, our government, our donors. So there's a lot to be done to improve the infrastructure for Jordanians for palliative care. In addition, that in KHCC, we have a Goodwill Fund where we support many refugees, whether Palestinians or Jordanians, and we really collect millions of, maybe around between $30 to $50 million in the past few years to try to support really cancer care for those refugees. So KHCC is providing care for Palestinians, for Syrians, and for also sometimes Libyans and those who are disadvantaged. We continue to promote whether cancer care or palliative care for refugees, and we try to reach more donors. We have support from St. Jude in the US to treat most of really pediatric oncology in Jordan. We treat, as KHCC, we treat about 95% of pediatric oncology, and now most of the pediatric cancer. But the problem is that people, to have access to the healthcare system is another layer. So the audience are coming either from our community or international supporters, NGOs, and even hopefully to reach the international community as well.
Thanks very much. I'm not sure, Tezer or Richard, do you have any thoughts on that?
Maybe Tezer first. Go ahead, Tezer.
Yeah, what I'm suggesting is, I mean, I am reading all the cancer control plans from around the world. I don't know how many of those cancer control plans has some chapter or section cancer control in crisis situation, either conflict, COVID, and whatever it is. So all cancer control plans, especially for the countries in the conflict zone, has to put cancer control in crisis situation, how to fund, how to implement, how to monitor, and this is one critical insight from my point of view.
That's an excellent point. And interestingly, last night we had one of the first talks on partnership was from a key organizer for the International Collaboration for Cancer Plan. So maybe we'll try and feed that back to them. That's an excellent point. Richard, do you have any thoughts?
Yeah, so I think Tezer and Omar are spot on. I mean, the first port of call is this is integrated into national cancer control plans. And, I've just been in Uganda. Uganda has 1.5 million refugees spread across 9 camps. And again, the plans are relatively silent on cancer. This is a problem across the world, as Tezer said. I think, sadly, in a sense, the work that Tezer and Omar have done was ahead of its time. What's happening now in Ukraine, I think, is starting to make the UN, HCR, and those other agencies start to change their mind, because we've seen huge numbers of refugees moving backwards and forwards across the borders. Cancer patients moving into Moldova, where the carrying capacity wasn't there, and we've had to move them out into Romania. And finally, I think UNHCR had kind of woken up to NCDs as being a critical issue now, but they simply haven't had the bandwidth or the intellectual ability to handle how to design the systems of referral. So I think the Ukraine will change things and shift the calculus here. The other area, of course, as Omar mentioned, is persuading bilateral donors when it comes to funding host countries that cancer and palliative care are a key component of bilateral health system support funding. You can't just be giving money for infectious diseases and child maternal mortality if you haven't got cancer and palliative care as part of the overall bilateral donors. How you expect host countries like Turkey and Jordan to be able to deliver the services? But I think it'll be Ukraine that will alter the picture, but it'll take a few more years yet.
Thank you. I'll see if there's any questions here in the audience. I don't have access to the online. Is there any questions coming up in the online chat?
I don't think there's any questions right now, but if anyone wanted to ask a question online, we could.
So maybe while we're waiting, I'll just ask one more question. You are the leaders in research. What do you think the next priorities are for research in this area, with a mind to the highest priority problems that need to be addressed?
Omar, Tezer, go for it first.
Yeah, I think the difficulties I'm facing with having the quality data. This is number collecting good data, because I could say that my data is quite good, but still it's a retrospective data. Still the limitations, selection bias, and there are many. So collecting the data is number one priority from my point of view.
Thank you. Omar, do you have any thoughts?
We are doing some research on the quality of implementing. For example, if we are improving palliative care delivery in Jordan, we are trying to test the efficacy of this change or intervention. So we are, for example, doing patient-reported outcome research to look into implementation of new tools and looking for the way these systems are working. And also, we are also improving the psychosocial spiritual dimension, as we probably get from the research that this is still lacking, and it's important and priority for Jordanians and non-Jordanians. So we are developing this service, and we are trying also to test the impact of this development. We're also maybe looking at whether another area, look at the cancer and the presence of probably non-communicable diseases along with it, to see whether there is something to be done also in a better way, and trying to change the system. There is also some research planned to be done in the camps of Syrians in Jordan, also in collaboration with Richard Sullivan and his team from King's and Cambridge University. So maybe to get hands-on data from Syrian refugees living in camps, and hopefully with a plan to improve the capacity of palliative care delivery in the camps for these Syrians. So this is some of the plans, hopefully in the next few months.
Thanks, Omar. Richard, do you have any thoughts?
Yeah, a few areas. I think, first of all, expansion of the phenomenal work that people like Omar and Tezer have been doing in the Middle East to other parts of the world. We still have very little local insights into sub-Saharan Africa, and, for example, refugees in the settings of Dahab in Kenya, Uganda, already mentioned. And we're also relatively thin in terms of understanding what's been going on in Latin America as well with the Narcowars, despite, Enrique de Soto's work. So I think there's an, geographical expansion of the work that's already been led from the Middle East. Secondly, I think HSR, there's a lot more health services research needs to be done to understand what affordable packages look like for the NGO community, for national funders and bilateral funders. And that requires, much more work between health economists, social sciences, and clinical experts. And finally, more practically on the implementation side, is compression of treatment pathways. As Omar knows, time is not a factor here. We're talking about needing to put much more hyperfractionation regimes in, shorter course chemotherapy, procedures which aren't going to need, huge amount of convalescence. So in other words, how to compress treatment pathways, because I think that's one of the biggest problems we have when we're talking to NGOs, is they say to us, look, these people, they'll come in for a week or 2 weeks and then they're gone. And strangely enough, that sort of research may benefit other fragile, low resource settings as well.
Thanks very much. I'll just do a last call here for questions. If not, actually, there's some audience members noticing the glass behind you there, Richard. So maybe I'll just wrap up then. And first of all, thank you for the important work that you do. And thank you for taking the time to share it with us today. It's been truly remarkable. I've learned a lot. And finally, the theme of this meeting is about how to build stronger partnerships and collaborations. And in the spirit of this meeting, thanks for being such a great exemplar of what an effective collaboration, research collaboration, care collaboration can do. So thank you on all those fronts, and really appreciate you taking the time. Thank you.
Thank you very much. Thanks a lot.
Wow. Thank you very much. Lovely to see everybody. Lovely to see you, Omar, Tezer. Hello, my friends. Great to see you.
Bye. See you. Take care. Bye.
Ciao.